Perfect. Can you all see that?
Yes.
Well, again, thank you for having me here. I'm excited to be here, and hopefully, at the end of this presentation, some of your questions would be answered, and you'll have a historical perspective of where we are at today with maintenance and where the field is heading. So again, thank you for having me here. So some of the themes that we're going to discuss today, what is the rationale for maintenance? Where did this come from? What are the agents that we can use? What are the side effects? How long should maintenance continue? And where the field is headed. So the idea of maintenance is not a new one. And, we've been, even before we had these novel agents, we were studying interferon alpha as maintenance for myeloma. And that's a lot more toxic than some of the agents that we have today. So that was studied, and then prednisone or steroids of some variety were studied back in the early 2000s, late 1990s. Before the data for lenalidomide matured, any benefit that we saw from interferon or thalidomide or prednisone was marginal and associated with a lot of toxicity, and really no clear survival advantage. So even though, in small subsets of the population, and some practitioners would still consider those agents before lenalidomide came on the horizon, they weren't really widely used or adopted, and the data was pretty controversial. Lots of agents had been tried, and the rationale for maintenance was, the disease is at a stable stage, but it's not completely eradicated, and using some sort of an agent was thought to sort of keep the disease under control and prolong survival. So you'd be avoiding intensive continuous therapy, so you wouldn't be doing the same type of treatment that you got during induction. You would be doing more of a lower intensity treatment, and hopefully keeping the disease under control, and hopefully living for a longer period of time while maintaining an appropriate quality of life. So that was where the idea of maintenance came from, and it's been going on for over 2 decades now. So, lenalidomide maintenance is the standard of care, and I always think of maintenance as, for me to adopt maintenance with a full heart, or with an open mind, it has to do more than just delay progression, right? Because patients generally they're less symptomatic from their disease than they were at the time of diagnosis, usually because you've given some sort of induction treatment, they're feeling better. And now, when they're fairly asymptomatic from their disease, you are giving them another agent with all of its associated toxicity, right? So when I think of this conceptually, the onus has to be for me to show that this treatment that I'm giving is doing more than just delaying a recurrence. Delaying a recurrence is absolutely important, but it has to improve, it has to improve survival. It has to make my patients live longer. It has to not be associated with a significant decline in quality of life. So for me, the bar for maintenance, and this is not just for me, for most of the community historically, the bar for maintenance has been that it prolongs overall survival, not just delaying maintenance. You don't want to give people, chemo just to delay the need for more chemo, right? You want them to live longer and better as a result of what you're doing. So there have been several maintenance trials for lenalidomide and myeloma over the last 2 decades, and it was in 2017 that the results of those 3 trials were pooled. You had 1,200 patients, and we comprehensively demonstrated that patients who were on lenalidomide maintenance lived longer. It was a 2.5-year difference between patients who were not on maintenance and patients who were on maintenance. And by oncology standards, that's a huge benefit, 2.5-year overall survival advantage. So it was in 2017 that it became the absolute standard of care pretty much throughout the world where lenalidomide is available, that after an autologous transplant, maintenance with len was the way to go. Before this, we had progression-free survival data. We had conflicting data from some of the trials where all of the trials had a progression-free survival advantage, right? But we had conflicting data on whether this translated to an overall survival advantage or not. But after 2017, it became fairly mainstream. I'd be hard pressed to find a single myeloma doctor that's going to say that maintenance does not prolong overall survival, and maintenance of some sort after an autologous transplant should not be considered. It became fairly standard, fairly universal. As you can see in this graph here, the number C, it pretty much benefited all patients, whether they're young, whether they're old, whether they're male, whether they're female, what the stage of the disease was, what the level of response of the disease was after a transplant and prior to initiation of maintenance. So that is the evidence base for which lenalidomide became the standard of care. And it's been the case now for several years. So this is so we're entering into a little bit of controversy here, right? So everybody agrees on lenalidomide, but the duration of lenalidomide is a more of a spicy topic. At least in the United States, lenalidomide is generally continued until either progression, or if if we're seeing a lot of toxicity and it's not worth the toxicity profile anymore. If you look across the pond in Europe, generally, the practice there is that the lenalidomide is given for a finite period of time. The US data, so we had the Stamina trial, which was a large, cooperative group trial here in the United States, and it randomized patients to different strategies after their first transplant. So patients could get either a second transplant, or they could get consolidation with additional cycles of VRD, or they could get len maintenance. So that was the first part of the Stamina trial. And in that, there wasn't really much of an advantage to doing intense strategies such as another tandem transplant or, consolidation with additional cycles. Len maintenance was adequate for the population as a whole. But the second part of that trial was interesting because it focused on the duration of lenalidomide maintenance. And generally speaking, the longer patients were on lenalidomide, the longer their disease stayed under control. And we're going to talk about the caveats of where modern therapies and where MRD comes into this. But generally speaking, if you ask a US doctor, they're going to use this data and others and be like, if lenalidomide has been working for you, if it's not causing a lot of side effects, generally speaking, the longer you stay on Revlimid, the longer your disease will stay under control. Now, we don't have overall survival update from this particular study yet, for at least for this analysis. And as you all may know, it takes a long time to show overall survival changes in myeloma. And we can talk sort of about that in the discussion. But in general, at least if you ask US doctors, and if you ask me, without MRD guided adaptation, which is what the future is going to be, today, if you're tolerating len maintenance well, generally speaking, the longer you stay on len maintenance, the longer your disease will sort of stay under control. And we'll talk about some caveats and some scenarios later today about that as well. So how are we trying to improve upon this? So I wanted to highlight some important trials that are going on. So as you all know, daratumumab is established as the standard of care for relapsed refractory myeloma. In every single trial it's been studied in, it's shown a PFS advantage. And it's also increasingly being utilized for newly diagnosed myeloma. We all can debate about, whether to use it up front or whether to use it later. But nobody doubts that daratumumab is a highly effective drug, and it's been a game changer, and it's changed the entire landscape of myeloma treatment. So one of the important questions is incorporating that in maintenance, right? And I am a big fan of the DRAMATIC trial, which we have open at the Huntsman Cancer Center, but it's answering two important questions, right? And it's powered, the endpoint is actually, do people live longer, which is essentially, one of the most important things that we want to know whenever we're talking about maintenance treatment. So in this trial, patients are randomized to either just Revlimid, which is the standard of care, right? And then the other arm gets daratumumab and Revlimid. Everybody gets treatment for 2 years, all right? And after that, Depending on whether you're MRD negative or MRD positive, there's another randomization that happens. So regardless of what arm you were on previously, whether you were on the Revlimid arm or the DARA and Revlimid arm, if you're MRD negative, you can be randomized to either continuing your therapy or stopping the therapy. And that is a very, very important, relevant question, because even today we're in this situation all the time, right? I have patients who are MRD negative who've been on maintenance for several years. The maintenance is affecting their quality of life. And, you know, I really wish that I had evidence to sort of stop their lenalidomide. And sometimes I do stop the lenalidomide after having a discussion with them. But this trial, once the data matures, is going to answer that very important question. Auriga is a trial that's sort of limited to patients who have MRD positive disease or residual disease at the time of enrollment. And in that case, they're comparing DARA and lenalidomide to lenalidomide alone. And it's a much smaller study. And it'll answer some important questions about whether you can convert MRD negative patients to MRD positive patients at the onset of maintenance to MRD negative patients. But Dramatic is the trial that will answer a lot of really, really important questions. So I look really forward to that data and to enrolling patients on this trial. So there's the Dramatic trial, which is by the Southwest Oncology Group. The Eastern Oncology Group, the ECOG Oncology Group, they are doing something similar where they're adding ixazomib to Revlimid. And again, there's if you're MRD, this trial is looking for if patients are MRD positive, then they sort of get randomized to an escalated strategy of either Revlimid and ixazomib or just Revlimid alone. So definitely, if you look at the common theme, we're bringing in MRD and using that to guide our decision making, and hopefully answering some important questions on how MRD can change our maintenance strategies. And then you hear a lot of talk about this, and there's a lot of, it's historically been a controversial and contentious topic. Do high-risk disease, do patients with high-risk disease, do they require some sort of another maintenance strategy? Because if you look at the data, we know that if you do just VRD, and especially if you don't do a transplant, but if you do just VRD and a transplant and len maintenance, patients with high-risk myeloma, those with 17p deletion or those with 414 translocation, they generally tend to relapse quicker. And so, we know that we can and we should do better, and we should try to avoid those earlier relapses. And that's where the concept of using something else or something in addition to Revlimid for maintenance comes in. And until recently, I will admit to you that the data that we had to support using something other than Revlimid or something in addition to Revlimid for high-risk myeloma was weak. I'll be the first to sort of admit that it was very puzzling, and as a trainee, I really struggled with the data for that, and I still struggle with that data. But generally, the simple way of thinking about it is that there were two main things that you could learn from looking at the entire data of maintenance for myeloma as pertains to high risk. Number one, those patients benefited less from lenalidomide. So even in that large meta-analysis that I sort of quoted to you earlier, in those with high risk cytogenetics tended to have less of a benefit with Revlimid maintenance. And then the other thing is from prior studies, and this is back in the thalidomide era, every time thalidomide was compared to bortezomib, to Velcade, patients with high risk myeloma did much better with Velcade. And sometimes they did a lot worse with thalidomide than doing nothing. So that's where sort of the concept of using a proteasome inhibitor as part of maintenance came in from. And until recently, higher quality data was lacking, but I'm sure you guys might have heard about the Forte trial. I don't know whether it's Forte or Forte, it's Forte, which is from the Italian group. And they recently presented an update at the IMW meeting. And patients were randomized to several different induction strategies. But the main thing that I'm going to focus on is the maintenance, right? So there was a second randomization in which patients were randomized to either Revlimid alone or Revlimid and carfilzomib or Kyprolis. And you can see here that the high risk myeloma, you have 172 patients, and the progression-free survival is definitely much better with the carfilzomib Revlimid in the carfilzomib Revlimid arm compared to the Revlimid arm. And this is with about 3 years of follow-up, and you're still seeing that there's a clear difference between the graphs there. And double hit myeloma, where patients have two different cytogenetic abnormalities that predict a poorer prognosis, you can see that there's still a clear difference in the progression-free survival curve. Now, if you remember what I said earlier, that generally, historically, for maintenance therapies, the community, the FDA has generally required more than just a PFS advantage. But it's hard to ignore this data, right? I'm all for OS, but sometimes our high-risk cytogenetic patients, they relapse quicker, and the longer the first remission is, the better it is, right? It's a big blow to one's quality of life, and you all can attest to that better than I can if there's a relapse that happens early. So it is important to prevent the first relapse early. And I don't know whether or not this will translate to an actual overall survival advantage if patients get carfilzomib later in the disease course, but it's hard to ignore this data. And most myeloma experts in the United States will tell you that if you have high risk disease, especially if it's cytogenetic high risk disease, right? High risk disease can be defined in so many different ways. But if you have one of those classical cytogenetic abnormalities that we know portends a poorer prognosis, generally speaking, a more intensive maintenance strategy is useful. And this maintenance strategy, it doesn't have to be you coming in twice a week and getting Velcade, right? Because that is not compatible with a good quality of life, right? So whether it's once every 2 weeks dosing or finding something that works for you, but generally speaking, it's more than just Revlimid. And until now we had weak data, and now we have the Forte data to sort of guide us in making those recommendations. So, we're studying daratumumab right now, as I mentioned earlier. But one of the interesting points is the Cassiopeia study, which this is a European study in which the Europeans still use thalidomide a lot more than we do. And in this study, basically the addition of daratumumab to Velcade thalidomide dex was evaluated. So without getting too much into the nitty-gritty details, it's hard to extrapolate the results of this study, the Cassiopeia study, to a US population. So if you look here, you can see that the first 3 graphs, right? Every graph other than the red graph is more or less superimposable, right? There's a lot of overlap between them. And the red graph, unfortunately, did a lot worse. So the red graph are patients who did not receive daratumumab in induction. So they did not receive daratumumab initially, and then they did not receive it during maintenance either. So this attests to the power of daratumumab as a drug, right? And these patients, the ones in the red arm, actually did not even get lenalidomide maintenance. So these were patients that were just observed after a transplant. So we know that those patients tend to relapse quicker. Now, whether you got daratumumab in the beginning, right, as induction, or whether you sort of got daratumumab as maintenance, the outcomes were comparable. For patients who got daratumumab during the beginning of treatment as part of a quadruplet, adding daratumumab as maintenance actually did not improve PFS. So that is a very important point. And this might have implications on how we think of and how we design trials, because we know with Revlimid, the benefit stays. Like even if you got Revlimid during induction, you can still get a benefit with Revlimid during maintenance, and it helps you live longer. But can the same be said about daratumumab? I think we'll sort of wait on the results of the trials that are currently accruing to show that. But I think that what this trial tells us is that more is not always better. And daratumumab is a fairly well tolerated drug, but it still is an inconvenience for patients, and it still causes low immunoglobulin levels and increase the risk of infections. So outside of a clinical trial in the United States, I think that the role of daratumumab instead of Revlimid as maintenance is unclear. Whether it adds to Revlimid is something that's being studied, but by itself, it's a little unclear. If you ask me, I've thought a lot about this sometimes, and I'd love to hear your thoughts about this as well from the audience, that I feel that if you're getting just daratumumab by itself versus just Revlimid by itself, I often think that the safety profile of daratumumab by itself is probably better than Revlimid by itself, especially when given at maintenance dosing, which is once every 2 months. But it's just that at this point in time, in the US, with the type of treatments we use in the US, the role of daratumumab as maintenance is kind of unclear. I feel like somebody did not get daratumumab up front. They got RVD and they got a transplant, and they're really struggling with Revlimid, and they still have some mild residual disease. I think that you can make a case that maybe we could try daratumumab for them based on these results. But otherwise, the role of daratumumab overall, I would say, pretty much remains unclear. So I wanted to leave a lot of time for the discussion. I didn't want to bore you with all of these slides here. So yeah, I'm part of a really amazing team at the Huntsman Cancer Center, and it's been great so far. And yeah, I'd love to have any questions that you all have. I haven't yet opened the Q&A tab here, but yeah.
That's okay. We already have some coming in. If you want to stop sharing your screen so they can see you a little larger, we are so happy you're at the Huntsman here in the area. And so thankful for your presentation, and thank you for leaving a lot of time for Q&A, because I feel like there's definitely going to be a lot of questions. Let's start with one of the questions that's been frequently asked. What about secondary malignancies? Do we have data about the increased probability of these secondary malignancies, such as secondary cancers, for those who are on lenalidomide maintenance?
Totally, that's a great question. So we do have long-term follow-up from each of these trials in which Revlimid was studied as maintenance. And if you sort of pool the data together, there's about a 5 to 6% chance of secondary cancers over long-term follow-up. Now, that's not inconsequential. Generally speaking, in every single situation, the risk of relapse and the risk of dying from myeloma is much higher than the risk of secondary malignancy. But it's not to be, I do not intend or want to minimize the risk. Different studies have suggested a different risk. In the largest individual trial from the UK that we have, the Myeloma 11 trial, the risk was about close to 4% at 3 years in patients getting Revlimid maintenance. About 0.5%, so 0.5% of patients getting Revlimid maintenance went on to develop, the really scary blood cancers, right? Like myelodysplastic syndrome or acute leukemia. Mm-hmm. Not inconsequential, it's not zero. But the one thing I always have a frank and honest discussion with my patients, and I sort of tell them that, if I were in your shoes or my father was in your shoes, the benefits of Revlimid maintenance in terms of decreasing death from myeloma and decreasing risk of relapse generally exceed the risks of a secondary cancer. And that's a decision that, it's up to each individual patient. But it's not inconsequential. It's higher with maintenance than it is without maintenance. Mm-hmm. Some of it is driven by the transplant process, and some of it is driven by the use of Revlimid during induction. And it's hard to always ease out exactly where this risk is coming from. And the other thing I hope is that, by incorporating MRD, we can be more sensible about the duration of maintenance. Mm-hmm. The longer you're on Revlimid, the slightly higher the risk gets. So it's an art that we're hopefully getting better at. Mm-hmm. It's not perfect, but in my opinion, for most patients, the benefits of being on prolonged Revlimid maintenance exceed the risks of secondary cancers. But we have to be vigilant, and we have to do better.
Okay, wonderful answer. And a follow-up to that, is there a certain patient population that you have seen more susceptible to these secondary cancers or malignancies that are on therapy?
That's a great question. So something that I have seen and something that the clinical trials also have shown is that the older you are, the higher the chances. So in patients from the myeloma 11 trial that I quoted, patients who were more than 75, they had a much higher risk. And so patients more than 75 who went on to get a transplant, who went on to stay on Revlimid maintenance for a long period of time, their risks were, the risks of secondary cancer were in the ballpark of about 15%. So, the risk benefit ratio will vary on each individual situation. But older patients are definitely, more at risk. And then this would lend to a discussion about whether in the current landscape, are we going to still keep on going to using, auto transplants for older patients? That's another discussion. I still think that auto transplants and len maintenance are one of the best kits we have in our toolbox, even though they're incredibly toxic. But generally, age is a well-established risk factor. Prior use of melphalan, people who've had multiple transplants, that's obviously another risk factor as well. But those are the big risk factors.
Okay, wonderful, thank you. Let's talk about your opinion about maintenance after immunotherapy, such as CAR T or BiTEs. What do you think about the role of maintenance therapy in that case?
That is a great question. So this is being actively studied right now. And outside of a clinical trial, so if my patient were to get a BECMA, ide-cel, one of the big reasons how I sell ide-cel to patients, right, when I consent them, is I tell them that, this will hopefully get you, it'll buy you time off treatment, right? Whether that's going to be 8 months, a year and a half, we don't know, but it's going to buy you time off treatment. And my patients really appreciate being off treatment, especially multiply relapse disease and they've dealt with the side effects of treatment, because no treatment comes without side effects. So as of today, outside of a clinical trial, I don't think that maintenance after CAR T is standard. And I think one of the ways we're studying CAR T earlier, right? So there's a trial looking at cilta-cel, and that's basically for newly diagnosed disease. And in that, we're basically looking at if that trial is not comparing patients to either cilta-cel or transplant. It's comparing patients who are not getting a transplant. But let's just do a thought experiment that this trial matures and we show that cilta-cel keeps you in a remission for like 5 years, right? And that's without any treatment, without any maintenance. That is pretty amazing, right? Without any continuous therapy, without any toxicity. That is, even though it would not be a direct head-to-head comparison to a transplant, and we could argue about the cost and the economics of that, but it would be hard to ignore that kind of data, right? Without maintenance, a single infusion of a one-time thing. But I think as the data evolves, as the currently enrolling trials, we get more information about it. I think some form of maintenance might, keep the disease under control for longer. But for today, I do not prescribe it off trial, and I actually sell it as a good point that I'm going to keep you off treatment for about a year or more, hopefully, with some of the newer CAR T products.
Yeah, it's a definite pro, a definite incentivizer for this CAR T. We're excited to see, what happens with that.
And then I forgot to answer the BiTE aspect as well. So
yeah.
Bispecifics are currently, they're given in cyclical fashion. So it's not a one-time dose like the way CAR T is. So they're being studied in clinical trials with combinations and also by themselves. But the concept of maintenance wouldn't technically apply to them, because you'd keep on giving the same the same BiTE every 3 weeks or every 1 week or every 2 weeks. As the data matures for people who have really excellent responses, perhaps we could do a maintenance schedule for the BiTE and give it less often. But all of that is really premature at this time, and we don't have really solid data on that.
Okay, thank you. There's been I really appreciate the information in the clinical trials that you shared during your presentation. There's quite a bit of questions regarding what about if they, most patients are just on Revlimid, and should they be considering adding Kyprolis to this, or talking to their doctors about adding Kyprolis? Is that even an option outside of clinical trials? Let's talk about that first, and then I'll continue on with questions about DARA.
I'm assuming that this scenario is for a patient who is high risk and has not been, for whatever reason, is just on Revlimid.
Mm-hmm.
Now, they find out about this data and they consider adding Kyprolis. So that is a difficult question, and I think it sort of depends, right? So let's say if somebody's been on Revlimid for a few years, if 2 or 3 years have passed, and their disease is still under control, right? So they're either MRD negative or MRD's not been checked and they're in stringent complete remission. I think for that patient, if you've been several years out already, I think I would not add Kyprolis in that situation, because your disease has sort of shown to us that it's stayed in remission with just Revlimid alone for a few years. So I think that adding Kyprolis would add toxicity and cost for an unclear benefit. Now, there's so many other scenarios where this could apply, right? So if you have high risk with, the problem with high risk patients is not to get them in remission, but it's to keep them in remission, right? So you have somebody who's was just 4 months out, and their doctor has recommended just Revlimid. And on cytogenetics, they have 414 and 17p, and maybe another cytogenetic abnormality. Those are patients that we know that statistically are likely to relapse quicker. And I would recommend that patient discuss the addition of a PI with their oncologist. And in the United States, it doesn't, we use Velcade. So the Kyprolis data is coming from Europe, but generally so far, if somebody did well with Velcade initially, we use Velcade. And I use that at once every 2 weeks dosing for maintenance. So it's nowhere as frequent or as bad as induction, and it's associated with a lot less toxicities. So Velcade would be an option as well.
Okay. Is Velcade, oh, sorry, go ahead.
Oh, sorry. Ixazomib is a weaker proteasome inhibitor, right? Trial after trial after trial, it ends up being positive, but marginally positive, and the magnitude of benefit is generally less than other PIs. So I'd be a little wary of using Ixazomib in this situation. I mean, it can be considered for certain subsets. But yeah, so I think each situation is different. But if you've been in remission for a long time already with just Revlimid alone, then I see less of a benefit of adding PI if your disease is stable.
Okay, thank you. I was going to ask concerning Velcade, is there any reason apart from the side effect profile of neuropathy that it's not being used more often as maintenance therapy?
Are you talking about Velcade?
Mm-hmm.
Velcade is, so I would say and I don't have the exact statistics for this, but in the United States, for patients who are on doublet maintenance with high risk myeloma, Velcade is used probably more often than Kyprolis. Now, I don't know the exact statistics, but Velcade is used pretty often for high risk patients. I think the inconvenient aspect of Velcade, and that would apply to Kyprolis as well, is that for maintenance, generally the community and patients have wanted something that's a pill. So that's how that when I try to convince patients to undergo an autologous transplant, part of what I tell them is, this transplant is going to be tough, but 3 months after you recover, I'm going to put you on a pill, and then hopefully it'll be a low dose of a pill and you won't have to come too often. You're not going to be spending your time at the infusion center. And that's part of how I sell it to them. And unfortunately, if you add Velcade, or if you had any other IV or subcutaneous drug, then that does require them having to come in, which is a quality of life thing, limits patients' ability to travel and live their lives and spend time with their family. So I think that's been one thing why Revlimid being a pill was so aggressively studied in randomized trials, and as opposed to Velcade, which has a role in certain subsets but not overall. And then obviously Velcade has a cumulative, dose-dependent, duration-dependent risk of neuropathy, and that is also obviously also very limiting in its use. For patients who haven't had neuropathy, with the initial induction dose of Velcade, They generally tend to do okay if you start Velcade, if you continue Velcade in maintenance at lower doses, but the risk of neuropathy is still there.
Right. And is there any data comparing Kyprolis with Revlimid versus Velcade with Revlimid and its success on high-risk patients?
That is a good question. So there is no data that I'm aware of. There definitely is no prospective data. If I look hard enough, I might find a retrospective study, but there's definitely no high quality prospective data. My philosophy in this situation is that if you have high risk disease, it really doesn't matter what PI you're on. You can continue the same PI you got during induction if you handle that fine. So if you got KRD, right, and you went to a transplant, you can probably continue Kyprolis maintenance at a lower frequency. And if you got VRD and you handle that fine, you can continue, some sort of a Velcade-based maintenance. So, and lots of people agree on this, that it's not the type of proteasome inhibitor that really matters. It's just the duration and having a proteasome inhibitor on board.
That makes sense. Thank you. Gretchen is wondering, if you go off of Revlimid after being MRD negative for several years and start to relapse, can you go back onto Revlimid to treat it? That's a question that I hear often.
Yeah, that's a fantastic question. So I would consider those patients as remaining Revlimid sensitive. So I would not consider those patients Revlimid refractory. And as of today, the best regimen that we have in terms of the longest progression-free survival for patients who are still Revlimid sensitive at relapse is a regimen that includes Revlimid. So that's daratumumab, Revlimid, and dexamethasone. So absolutely, Revlimid still would have a role if your disease started coming back after you had been off Revlimid for a long period of time. And we don't want to write off a very effective drug just because you've been exposed to it in the past, if you're not refractory to it.
Mm-hmm. Wonderful. Okay, lots. Let me try to find the question. I scrolled right past it.
Go ahead.
Oh, you're welcome to say something if you'd like to.
I guess I'm scrolling through these questions. A lot of what I said today was maintenance after a transplant, right? And that is what we have the most solid data for. Generally speaking, so let's say you're a transplant ineligible candidate, right? Or you decide not to do a transplant. Generally speaking, although the data is not as robust in terms of translating to an overall survival advantage, some form of maintenance is the standard of care, and it's been shown in trial after trial that some form of maintenance, some form of continuous therapy translates to a longer progression-free survival, even if you're not undergoing a transplant. So let's say you got VRD, right? And you did not undergo a transplant. So after 8 cycles of VRD, you would drop to just Revlimid alone. And that is the standard of care. And that would lead to a better disease, better long-term disease control, better progression-free survival than just stopping treatment altogether. Mm-hmm. So trial after trial after trial, and this is before the era of MRD adapted therapy, trial after trial after trial, whether it's transplant patients or non-transplant patients, has shown that some form of therapy generally helps keep the disease under control for longer. And we all really want to change that, right? Like it does hurt my soul that week, when I tell my patients with myeloma, when I see them for the first time and I tell them that, as of today, most, we recommend some form of continual therapy. Like I can see how it crushes their soul to hear that they're going to be on some treatment all, forever. And then I sort of follow it up by telling them that I hope that this changes. And, as we get to know each other better, and then as the data evolves, my hope is that we can, carve out some long treatment breaks and hopefully even treatment discontinuation for you.
Right. Let's talk about MRD and how it plays a role in the topic of maintenance therapy. We've mentioned it a couple times. What do you recommend if you see MRD testing? So your patient is MRD negative. What are the next steps you take with that patient if they're currently on maintenance therapy?
That's a great question. So I will say that I want to start this by saying that we do not yet have solid data on how to change our practice based on an MRD result, all right? But I'm going to give you some scenarios and tell you what a reasonable approach would be. I'm not saying that this approach is backed by solid prospective evidence, but I think that we can make educated guesses and inferences. So let's say I have a patient and they've been on Revlimid for like 5 years now, all right? And their disease continues to be in a remission. They're in SCR, they check their MRD, and their MRD is negative. I would think that for that patient, I can have a discussion with them, and especially if Revlimid is causing some issues, especially if it's causing mental cloudiness, because that Revlimid does that to a lot of GI issues, I would feel comfortable discontinuing maintenance for that patient. Now, if somebody's at a 2-year mark and they're MRD negative, and this is the first instance of being MRD negative, I probably would want to keep them on it, because emerging evidence has shown that it's sustained MRD negativity that matters more than a single time point. So, for that patient, if they just became MRD negative, they're only 2 years out, I'd probably keep it for a year more. And then if they're still MRD negative, I would tell them that I don't have solid data yet, but I don't think it's unreasonable. I can say that your disease might come back a little earlier, but I don't really think it's going to affect your overall longevity. But these are all just, and I acknowledge that there's no solid data in this situation. But from what we know from other studies, and from what we know about the disease, and from what we know about how MRD negative patients in general, what to expect from their outcomes, I think it's reasonable to have these discussions, especially if people have been on Revlimid for a long period of time and they're MRD negative and they've been sustained MRD negative.
Wonderful, thank you. What's the role of Ninjaro in maintenance therapy?
It's a great question. So, as I mentioned earlier, in trial after trial after trial, Ixazomib or Ninjaro has a benefit, but it's generally less of a benefit than other proteasome inhibitors, all right? And about a month ago, US oncologists were sent this email, and this is all preliminary, and we don't know the exact, science behind this, but in the 2 trials in which Ixazomib was being studied in maintenance, one was a post-transplant maintenance, and the other was a non-transplant maintenance. Patients randomized to Ixazomib versus placebo, and we're not even comparing to Revlimid, right? We're comparing to observation, had worse overall survival. They had a longer progression-free survival, but worse overall survival. So I was not a big fan of using Ninjaro in this situation previously, but after that update, and I need to know more data about those updates, and I haven't seen a paper or an abstract or just a news alert. I would not start people on Ninjaro as maintenance unless they were really extreme circumstances, and even then, I'd be like, I don't know whether this is going to help or not. In the past, before this news update came, I would consider it if somebody was had a lot of different issues with Revlimid, or they had high-risk disease and they absolutely did not want any other proteasome inhibitor, and coming to the infusion center was really onerous for them. So other than those small, really unique subsets, I would not recommend use of Ixazomib as maintenance today.
Thank you. There's quite a bit of questions. I'm trying to combine the idea of several questions. What is the role of Revlimid in maintenance therapy? Is it supposed to be attacking that original myeloma? Is it preventing further clones from developing? And then I have some follow-up questions to that as well.
That's a great question. So, there are different hypotheses that are out there, but we think that it continues to modulate the immune system to help keep the original myeloma clone that you had under control. We do not expect the Revlimid alone to sort of be a curative strategy. I think, if you ask me philosophically, that we do cure a small amount of patients with melphalan, right? There are about 10-15% of patients after an auto transplant whose disease never relapses, and this is with VRD followed by or some other triplet. This is not in the era of quads. This is not in the era of BiTE or CAR-T. But 10-15% of patients, disease never comes back after a transplant. If we knew what those patients were, if you knew how to identify those patients, and I don't think that, I think that melphalan alone would have been enough for them. But it's just that we don't know, right? Even with MRD, even if you're MRD negative at a single time point, the disease still sometimes comes back, right? So it tells us that even our current MRD assays do not identify every single myeloma cell, unfortunately, because MRD negative does not mean cure. Even sustained MRD negativity, the chances of disease coming back is much lower, but sometimes it still comes back. Tells you that you've not looked for, you don't have a tool that catches every single myeloma cell. So I think that, maintenance, conceptually, how I think of maintenance is that it modulates the immune system and helps keep the disease under control for longer. It's not by itself eradicating the disease, because if induction and the transplant didn't eradicate the disease, I don't think conceptually that Revlimid alone at lower doses is going to eradicate it, but it's going to harness the power of the immune system to keep that clone under control, maybe prevent new clones from forming. That's how I conceptually think about Revlimid maintenance.
Awesome, thank you. In addition to that, following up, what about patients who are MRD positive? Does adding more drugs to that maintenance therapy help them achieve MRD negativity?
Good question.
Because of the role that it's playing.
Yeah. So this is a highly contentious topic, right? We're entering into some really like muddy waters here. A lot of myeloma doctors will tell you, and they have their own evidence to support them, that finish the job, or do intensive treatment to sort of try to eradicate the disease. So if you're MRD positive, get more treatment and become MRD negative. My counter argument is that we don't know, and there's no prospective trial as of yet that tells us that converting in this situation, converting an MRD positive patient to an MRD negative patient will make them live longer. So when we know that so let's say, you're cruising along after maintenance for a long time, and then you become MRD positive. If I give you aggressive triplet or aggressive quad, I know the side effects of that. I know that it's going to cause some side effects. I know that it's going to cause financial toxicity. I know it's going to change your quality of life, and you're going to have to come in frequently. And I might even make you MRD negative. But did I do you a favor as opposed to just treating you when we saw a little bit more of a disease evidence? Nobody knows the answer to that question. And educated, well-informed people can make different decisions. As of today, I don't think it's standard to treat just if you're MRD positive. And I think that you can be exposed to a lot of over treatment, a lot of financial toxicity, and a lot of other toxicity just for doing that. Now, nobody wants to keep the disease, let the disease grow until a point it affects your organs, right? Like, in no way do I want, that to be the message. But generally speaking, I think that if you're just become MRD positive, doing advanced multiple drug treatment, in my opinion, is a little premature. We hopefully will get data about this in the future on how to approach MRD positivity without any other signs of relapse. But as of today, we don't really know. And I personally would not aggressively treat just for that MRD positivity. I would have a discussion with my patient, but today I find it hard to justify the risk benefit ratio. If I know that people live longer or live better as a result of me doing that, sure. But I just don't know that today.
Yeah, thank you so much for that. Let's jump back to talking about Revlimid itself. One of the questions that I had that has been repeated in the question and answer section, what signs should people be looking for? You said they would be removed because of toxicity. What signs of toxicity are there in which the patient should be removed from Revlimid?
That's a fantastic question, and it's not an uncommon scenario. So even in the clinical trials, and clinical trials recruit really fit patients, about 30% of patients discontinued Revlimid due to toxicity. All right, so it's a long-term game, and like it is tough on patients. So the main side effects that I sort of see at maintenance dosages is that fatigue is one, right? So people feel a whole lot better during their week off, but they feel really run down during those 3 weeks. And suddenly it comes to a point where, you try a decreased dose, you try every other day dosing, and it still doesn't work. And you just are left with no option but to take it off or try something else. So that's one. GI issues are another. Sometimes it causes constipation, sometimes it causes diarrhea, sometimes it causes like mild abdominal pain or abdominal discomfort. I see that a lot as well. I also see people, and it's hard to put a finger on it, but people just don't feel as sharp as they were off Revlimid. So like, mental cloudiness, forgetting words, just not feeling as sharp as they were. And sometimes it comes to a point where, they feel so dramatically different when they're off Revlimid, and so much worse that I have a discussion with them and I put them off it because I feel like it's not worth the risk profile. Those are the main side effects. Generally speaking, those allergic reactions that we see, skin rashes, and we see them earlier. So like, we see them at higher doses earlier with induction. So I personally don't see a whole lot of them when people are on maintenance, but I definitely see a lot of these side effects that I mentioned.
Awesome, thank you. Let's talk about the rash for a minute, because that notorious Revlimid rash, right? What are some maintenance options for patients that have been in their induction therapies or whatever it may be taken off of Revlimid because of side effects such as rashes?
That's a great question. So if they absolutely could not tolerate Revlimid at all, prior to this Exasamib data, Exasamib would be considered. You can consider using Velcade at every 2 weeks dosing. You can now make a case for using Carfilzomib. You can, as I spoke earlier about daratumumab, you might have to fight with the insurance company. But I think that for somebody who did not get daratumumab earlier, so they didn't get daratumumab as part of their induction, you can sort of use the Cassiopeia data from Europe and make a case for daratumumab once every 2 months. And I think the risk benefit profile of that is compelling. That's not standard, and insurance may not approve it. It's not approved in the US for that indication, but those are things that I would sort of try to get approved and try to work with in that scenario using one of these agents. I'd probably start with the PI because a proteasome inhibitor, especially if they tolerated that well, because we have better data for maintenance and more experience with it. But this is one scenario where I see the rationale and the logic of using daratumumab, because at every 2 months, I mean, it still causes some side effects, but it's often like, I don't want to speak for patients, but the patients that, that get it at monthly dosing or less, like they generally don't have a lot of side effects from that. So that's something I would theoretically consider and work with the insurance company for.
Okay, and I would add, join a clinical trial, because the more people we have involved in these clinical trials, the further we can accelerate myeloma research. So that would be another option for patients as well.
Yeah, although a lot of the clinical trials that we have build on Revlimid,
True.
but yeah, if it was a clinical trial that does not build on Revlimid, that would be fantastic.
Yeah.
We are looking at other strategies as well, but yes, Revlimid is the backbone for maintenance, in the landscape of today's clinical trials. But totally, well-guided clinical trial is often one of the best things that we can offer to our patients.
So you might not know the answer to this question, but it's been asked several times, so I figured I'd send it your way. We've heard a lot about a biosimilar generic drug for Revlimid. Have you heard anything about that and know when it could possibly be available for people in the United States?
I have heard about it. I have read about it. I think that for all practical purposes, it is the same as Revlimid. That is the the trade official version of Revlimid. And if it were available in the US, I would have no qualms using it. The unfortunate reality is that drug companies want to fight to keep their drug patented for as long as possible. And I know that there have been several lawsuits and several issues with generic versions of Revlimid. So I don't know the answer to that question. I probably should be better aware of this than I am. So my apologies for that. But if it were to get approved, I would have no qualms using it. And I think that if it gets approved and if it's cheaper, I think it would be great for our healthcare system and great for our patients. for as long as we keep using Revlimid as maintenance.
Awesome, thank you. I have just a couple more questions. I know we're getting close to the end of the session, but I want to make sure that we hit a couple more if you're okay with that and you have a couple of minutes extra time. Steve is wondering, we talked a lot about maintenance therapy, the role of maintenance therapy in high-risk myeloma. What about low-risk myeloma? What's the role of maintenance therapy? Is it needed for a long time?
That's a great question. So we don't use the term low-risk myeloma anymore. So we use the term standard risk and high risk, right? For standard risk myeloma, generally maintenance with Revlimid is enough. And a lot of the clinical trials that we have will answer the question of whether it's okay to discontinue if you're MRD negative. In the US, even for standard risk myeloma, the general de facto way of doing things is to keep giving Revlimid until progression or until there's toxicity. But I think that if you've been in a really deep remission, whether that's MRD negativity or whether that's an SCR and you haven't checked MRD negativity, and it's been several years, and it's been like 3-4 years already, and you're doing well, but the Revlimid doesn't, it makes you feel a little unwell. I think it's reasonable to have a discussion with your primary myeloma doctor or your oncologist, and you could make a case that maybe let's take a break from Revlimid for a bit. I did show data earlier, and that was mostly standard risk patients, that the longer you are on Revlimid maintenance, generally speaking, the longer your disease stays under control, right? So that's average for everybody. That's a general recommendation, but we should look at each patient as an individual and look at them. And for some people, if they're in a really good remission, if they're MRD negative, it's been several years, I would argue that the benefits of treating don't outweigh the side effects, and you might make a case to discontinue them, which is why I can't wait for the MRD adapted data to mature so I can make these decisions. So yeah, it's definitely worth discussing if you have standard risk myeloma and you've been in remission for a really long time.
I agree with you. I'm excited to see how this MRD data plays out so that we can be making more informed, well, not me, I won't be making the more informed decisions, so that you can make the more informed decision for your patients along with your fellow multiple myeloma specialists. We'll finish out with the question that's been asked several times by our younger patients. What about continued maintenance for younger patients? Do you see their age, whether they're old or young, as an argument for staying on Revlimid a long time?
That's a really good question. And I think that we don't have solid data to guide us. The bulk, myeloma is rarer in younger people, right? So the bulk of the patients that we have on clinical trials are like 50s, 60s, 70s. I will say that if you're, so I'm just like thinking it out loud, these hypothetical scenarios in my head, that if you have a younger patient and they're on LEN maintenance and they're not yet MRD negative, there's still some residual disease, I would probably want to keep them on continual treatment longer than if that same scenario was played out in a 75 or 80 or 85-year-old patient with more comorbidities. Generally speaking, and again, age is physiological, it's just a number, right? But generally speaking, younger, fitter patients handle maintenance better. And I would need to have more compelling data to discontinue maintenance for them, because I want, I want everybody to live as long and as well as possible. But sometimes like these discussions are tougher and more important, and they're they're important for everybody, but they're tougher with these younger patients, right? So yeah, my threshold for continuing Revlimid, I would want to continue Revlimid in that situation.
Wonderful. I said that was the last one, but then our audience really wants to know, is Pomalyst a good alternative to Revlimid, and where does Pomalyst play in maintenance therapy? So
that's a great question. So we don't have really solid data on using pomalidomide as maintenance after a first transplant. So pomalidomide, and the first question I'm seeing it is 4 milligram pom equivalent to LEN 10 milligram, and we don't really know that. They're different drugs. Pomalidomide still has an activity in LEN refractory disease. It's not really standard to use POM by itself as maintenance after a first transplant. POM can be considered in obviously patients who relapsed, and they relapse and then they get some type of triplet as part of their disease for relapse, and then let's say they get back into a really good remission, then you could sort of consider keeping them on pomalidomide, but it wouldn't be a go-to choice after a first transplant. Sometimes when we've done a second transplant, when I was a fellow at the University of Kansas, we use POM maintenance as after a second transplant. And again, because we don't have solid data to guide what to do after a second transplant, but not after a first transplant.
Okay, wonderful. Thank you.
I guess I'll answer this ELO question as well. Just I see that there. So I've actually seen patients where they were getting ELO maintenance where they shouldn't have been. I think that elotuzumab is a drug that works in myeloma, but it works if you give it with something else. By itself, it does not work. So ELO is given with another IMiD, so it'll be given with like lenalidomide or pomalidomide, and then it's shown activity in relapsed refractory disease. It is not standard to use elotuzumab as maintenance. The drug does not have single agent activity. It does not work by itself. And generally, when you're talking maintenance, you're using a drug just by itself, or sometimes two drugs. So it's not standard to use elotuzumab as maintenance, is what I would say.
Okay, wonderful. There's more than 40 questions left. Unfortunately, we don't have the time to answer them all, but we really do appreciate your time, Dr. Mohyuddin, and we hope that you just continue to have success in your research and come back to speak to us again, because that was an excellent presentation. Thank you for your time and your shared knowledge. We're going to finish with just a couple of outro announcements, and then we will be done for today. So in October 2021, we will be hearing about cancer survivorship and how we can optimize our wellness. That will be, I will get you more information about that event as we work out all of the details. You may be interested in other upcoming community events. Wednesday, September 22nd at 1 p.m. is our selinexor support group chapter, which is finding solutions to XPOVIO side effects that work, with head of product at HealthTree, Todd Foster. There could be many side effects that come with XPOVIO, but that shouldn't keep you from wanting to try the successful treatment. Learn from other patients like you what their side effects were and how to successfully overcome them. The 23rd is our African American myeloma chapter. We're joined by Nurse Amy Pierre. She will be discussing how to overcome disparities and fear in order to effectively communicate with your doctor or medical team. And then don't forget, Saturday the 25th at 12:30 p.m. Eastern is our Myeloma Roundtable. And we are going to be talking about where are we going, and assessing the state of myeloma with two world-renowned multiple myeloma specialists, Drs. Rafael Fonseca and Ola Landgren. On the 28th at 1 p.m. Eastern is our Nutrition and Wellness for Myeloma chapter. We're going to be doing part 2 of the Making a Successful Transition to Plant-Based Nutrition, discussing healthy swaps for ingredients we're probably better off without, adapting recipes, building quick meals, and finding more online resources to support our journey. The link to sign up for any of those events and even more events that I have not mentioned today is found at the bottom of this slide and will be sent out in the follow-up email within 48 hours of the event's conclusion. Another thank you to our sponsors, Bristol-Myers Squibb, Takeda Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, San Oncology, and Genentech. And thank you for helping us build a strong myeloma crowd community. We appreciate you and hope that you have a great rest of your day. Thank you.